do the introduction first. Hi, everyone. I'm Aini Teo, the academic head of School of Social and Health Sciences, and also the moderator and host of today's session. It's my pleasure to welcome all of you to the fourth webinar of the Emerging Leaders series. Today, we're going to focus on conversations in the last year of life. Before we start the webinar officially, just a few housekeeping notes. First, the webinar will be recorded for publicity purposes. And our panelists will each give a presentation first, Chris followed by Geraldine, and Q&A will be at the end of the presentation. If you have any question at any point of the webinar, you can post your question through the Q&A function. You may find the Q&A button on your Zoom below. We'll address your question through the Q&A session. There will be a satisfaction poll and survey at the end of the webinar. We encourage you to complete the survey to let us know any feedback that you have. Lastly, if there's any technical issues, please use the chat button to communicate with the event organizers. Okay, without further ado, please let me introduce our panelists today. Our first presenter is Dr. Christopher Loh. He's an associate professor in psychology at JCU Singapore. He also holds appointments in the Department of Psychiatry and the Dalla Lana School of Public Health at University of Toronto, Canada. Chris has expertise in fields of medical and health psychology and palliative and supportive care. His work has concerned the assessment and improvement of quality of life and quality of care in geriatric populations, especially patients and their families coping with advanced or progressive illness. Our second presenter is Ms. Geraldine Tan Ho. She's a research fellow and senior counselor with rich clinical experience in the field of palliative care for children, youth, and older adult patients and family caregivers. She is a passionate advocate and therapist for research and interventions that facilitate meaningful dialogue on life and death issues, as she believes that these endeavors will lead to individual catharsis, community empowerment, positive social change, and the holistic enhancement of our healthcare ecosystem. Geraldine is a certified thanatologist, author of numerous end-of-life care publications, and currently pursuing a Doctor of Psychology. She also sits as a co-chair on the Community Engagement and Communication Committee of the Singapore Hospice Council. In this webinar, Chris will provide an academic overview, while Geraldine will discuss family dignity intervention, or we call it FDI. So now I'd like to invite our first speaker, Dr. Chris Loh, to start his presentation. So please welcome him.
Well, thank you for coming in this sunny afternoon for such a difficult topic. Yeah. So here we're going to talk about conversations in the last year of life. And we start off perhaps with giving you a bit of an overview of what might be considered the Western model, common Western model concerning the psychological and social effects of diagnosis. So it's often imagined like being a bomb going off in someone's life, with the repercussions, the shock, especially of facing that end-of-life diagnosis, beginning with the patient, kind of reverberating outwards to affect the caregiver, the family, and the larger community. However, interestingly enough, sometimes thinking about more of the Asian setting, when the diagnosis might actually be revealed to the family first. And it might actually kind of almost work a little bit in a different order, where the family and the caregiver may actually have to first deal with the effects before it actually reverberates back and forth. So that's one of the interesting cultural differences that can exist, depending on actually who gets the information first concerning a terminal and life-limiting illness. Now, on average, in the kind of work I've done before, I've studied patients with advanced cancer. And in general, when they were diagnosed with a metastatic, advanced and incurable disease, they had about 1 year of life left to live. And so 1 year, that's both perhaps seemingly a lot of time and also very little time to consider and contemplate, well, the life that you've lived and the time and life that is yet to remain. And what are you going to do with this time, you and your family and your loved ones, to kind of make the most of that and prepare for the inevitability of death. Now, the emotional responses can be quite dramatic and can really range, from denial and depression to actually an opportunity for spiritual well-being and life affirmation. And I think to give you an idea of the rates of depression, it's probably about 20% is a number that's thrown around. The rate of clinically significant depression in patients with advanced cancer, about 20% is a common number that comes up. And that might seem like it's hard to say depending on who you are. That might not seem as high as you might expect. Sometimes lay audiences expect it to be 90%. Everyone gets super depressed. Everyone feels awful. But actually, there's substantial variation. Many people are able to adapt. Many people are able to carry forward. But again, about a fifth of the population, it does face significant depressive reactions. Now, when we think about patients and caregivers, they can actually form an interlocking system. Now, the caregiver, the primary family caregiver, is often the one that is most intimately kind of associated with the patient, the most tied, because they're really caring for that patient in that final year. They're often making decisions and so forth. And the distress is not actually equivalent. We find caregivers actually to often be as depressed or as stressed as patients, if not actually even more. And when we kind of examine the relationships, I guess it's because for the patient, as their life begins to close, their psychological world shrinks a little bit more, whereas the caregiver has to take more and more responsibility and more, I suppose, the burden, right, of what to do in the final phases. One interesting finding from this work is that the ability to tap into social support, to connect with other people, is very crucial to how well people do. And it's for at least two reasons. One is the emotional relief that can come from being able to talk to people and share one's experiences. And the other, it has to do with the instrumental aspects. The practical burden of caregiving can often be alleviated with help from other people. Sometimes we can find there's a real vicious cycle that can occur with regards to the end of life and the poor quality of life and poor quality of death that can occur at that period. And what it can happen is like this. It starts off with a particular families experiencing bad quality of life at the end of life. And it can lead to, when you see that happening, it can really undermine faith in the healthcare system to care for your loved one. And assuming that poor quality of life continues, it can then lead to a poor quality of death, which can really affect the family, affect the larger community. It can complicate the grief that comes after survivorship. Now, this can lead to kind of further death stigma. People are becoming even more afraid to talk about and think about death because they've had this bad experience with how the end of life can look, which leads to more kind of avoidant coping, poor preparation in families because they're not willing to think about the end of life, not willing to talk about it and prepare for it. It just, perpetuates then this cycle. Then you get poor quality of life again. Next time, another family member comes up because they're not talking, thinking in advance. And so the cycle can go. In terms of cultural change, a good deal of, the community outreach efforts of palliative care and supportive care professionals is to try to change these death attitudes so that there can be a less fearful discussion about this obviously difficult topic. And palliative care is really an interdisciplinary caregiving approach. And it's really meant to improve quality of life from people who are suffering from serious, complex, chronic terminal illnesses. And of course, as a palliative care researcher and clinician, we're trying to target individual level kinds of adaptation, especially the expression of end-of-life preferences and wishes. Also with the caregiver and families, so that they can have that, I guess, share more in the meaningful experiences rather than being caught up in the tragedy of the situation. And again, hopefully these effects can eventually permeate to affect the community by improving kind of awareness of care and ultimately accessibility to good care. Now, within Singapore, it's common actually to inform, actually not just in Singapore, but in many Asian contexts, it's common to provide diagnostic information, prognostic information, first to the family or to the primary caregiver before it actually goes to the patient. In some cases, the healthcare team may not actually directly communicate the diagnosis to the patient. Rather, it's left to the family to decide the timing of that and how to do it. Even though we know actually in many surveys, including in Asian context, that most patients do want to know the truth about their illness. This is, of course, always an individual preference. Some people may indeed not want to know, and that can be respected and should be respected. But most people actually do want to know. But there's often a presumption that if there's kind of collusion from the family to hide the diagnosis or the high prognostic information from the patient, there's often this idea that, well, the patients may lose hope, may become depressed, they just can't handle the emotional consequences of it. And it's better for the patient that they not know, that they can be more at peace, be happier in the final year, rather than having to grapple with, this information. Sometimes the patient, the family itself is in denial or is in conflict, can't decide whether they should or shouldn't. And so again, that information is delayed and not maybe given to the patient. In terms of whether or not the patient may actually lose hope, may actually fall into depression if they're not given the information. In some cases, you can protect perhaps a patient for some period of time. It can be true for a certain period of time. But eventually, the illness can't really be hidden. You can feel it in the body. The patients can feel themselves becoming sicker and weaker, and they can know something is wrong. And actually having that hovering over them, that kind of ambiguity and the silence about it, it can be actually very painful and very, actually it's associated with worse quality of life at the end of life because of these unresolved issues that aren't ever really talked about, can't really be addressed. Really, advanced disease provides both an opportunity and a threat, right? Those two things are tied. The magnitude of the opportunity for connection and for life closure is kind of in lockstep with the threat, right? The threat of the death anxiety that the situation obviously entails. My old supervisor used to talk about what we're trying to encourage in patients is a sense of double awareness. That is, you want people to be able to face the realistic fears and concerns associated with dying, yet not be overwhelmed by it and still be able to kind of focus enough on the meaning and value that's still to be had in the time remaining. And this is constant back and forth, or seeing both things at the same time is the main challenge, to be able to do that. But of course, people may tend to be, diverted to one or the other. Yeah, and sometimes to an extreme that's not obviously adaptive and not healthy. So extreme avoidance of death anxiety and means you not preparing, neither the patient nor the family. And it's not really helpful to cling to unrealistic hope to cling to, say, curative treatments that don't exist, experimental drugs that are far too expensive and really won't help, or so-called cures that are really no such thing. It really just takes away actually from the ability to focus on, again, making the most of the time that's left. And sometimes there's kind of a magical thinking that's involved. It's very common that if we just don't think about it, it's not going to happen, won't go away. And so sometimes the reaction, even when a patient brings it up, like to want to talk about death or to broach it very with a family member, with a primary caregiver, sometimes the reaction is, don't talk about that. Don't talk about that because you're giving up on us when you do that. So why do some people cope better with the end of life than other people? And you can think of, at least from an Ericksonian perspective, that the final life stage is one when you're approaching the end of life, is the wonder, does my life have meaning? And really that can be answered and resolved based on the kind of life you've lived. And it's really based on the stage-like progression through the major developmental challenges that Erikson has kind of laid out. And it starts, of course, from almost from the earliest stage, right? From very early development, the building of trust, the ability to trust others, to rely on other people, and have close families right from the beginning, close parents, can lead you to develop a sense of greater independence and autonomy. You can learn how to then initiate and choose the life that you want to live and develop your competencies, discover who you are, and develop intimate relationships. And all of this, if you move through life in this stage-like way, accomplishing each of these earlier developmental milestones, you can come to a point where you can feel that your life has made a difference. And the interesting thing, I think, about taking this kind of perspective is that advanced disease, it can kind of reactivate all these developmental challenges because the disease itself strips away actually the competencies that you've built up over a lifetime. It takes away possibly your ability to relate to other people. It can take away your sense of who you were because now you're a patient, not someone who's been well. It can take away your competencies, your sense of independence, and can really threaten and challenge your ability to trust independent others because, of course, of the incredible dependency needs at the end of life. And sometimes the loss of dignity can refer to really the stripping away process, and especially the loss of the earliest competencies that we're so used to, the ability for self-care, right, for mobility and so forth. Now, I think a key finding and a key idea here is that that sense of generativity is one of the second most last life stages, that sense that you've made a difference in the lives of others. And that's because again and again in interviews and discussions with patients at the end of life, it's this sense of having made a difference to others, having been able to nurture and contribute to development of other people is what gives people a sense of life meaning. And so that's why family is so important at the end of life. That feeling of connection and of wholeness. Now, conversational strategies, sometimes people may avoid discussions of when they talk about death, and and strategies that people may use include reversal, or diversions, or they may kind of diminish the topic of death and any kind of threatening concerns when those concerns come up. And it can be a challenge when engaging in conversation to get people to engage in a more conversational mode that can allow them to explore what it means for them to die, the kinds of preferences they may have at the end of life. And sometimes in order for them to get into that contemplative and exploring kind of train of thought, they need to have sufficient disclosure. They need to have a chance to be able to really express and talk about their feelings about the life that they've lived and about the life that they're living right now before they can really talk about and contemplate these more difficult things. And really the idea is that we're trying to generate a reflective space for people. And this is why psychotherapy is so vital. It's sometimes the only space some of these patients and family members may have where they can talk to someone who doesn't necessarily have per se that personal stake in the way that talking to another loved one has. You can talk to someone who is more neutral, who perhaps has seen more cases and can understand what this process really entails. And they can afford the patient or the client or the family member a chance to express and disclose, and then allow them a chance to reflect before perhaps making some thoughtful decisions about what to do rather than reactive decisions. Now, within medical decision making, some of these decisions, the burden of that, sometimes we talk about relational autonomy. And this refers to the idea that personal choices are often made really in consideration of what close other people also want. So sometimes people don't really just want to make a decision regardless of how it affects other people. They do want to weigh the considerations of their family and their loved ones who are affected by these decisions. And within an Asian context, the relational aspect may actually be particularly large. And at least in Asian context, it may be very common for geriatric patients to want to place much of the responsibility for decision-making on the adult children, actually. And there's a number of reasons for why that can happen. Sometimes it's because of the complexity of the information and stressfulness of making those decisions. Sometimes it's the death anxiety that the patient doesn't want to think about these things. But a major reason, perhaps maybe the most common reason, may actually be the elder parent just wants to be less of a burden on their families. And the idea there is that they're thinking, you know what, I just don't want to impose what I want on my family. I'll let you decide. Whatever you want to happen, I'll go with, because I just don't want to I don't want to impose what I want on what you should do, what you think is best for the family. But that actually may be counterproductive, because in the face of that ambiguity, we can find that actually the family caregivers may tend towards very conservative life-prolonging treatments that may ultimately be futile. It's a lot of stress on the caregiver to have to decide, and part of that on what to do. And interestingly, there was a study done by some colleagues here at JCU, which looked at why this may be the case. And they found that sometimes it's because of the sense of filial piety, especially the sense of filial obligation that the child may feel toward the parent, that when the adult children, that adult caregiver feels a strong sense of obligation to take care of the parent, they may, in the face of that ambiguity, then choose the kind of most kind of invasive, most life-prolonging measures, which actually in this context may actually increase the suffering of the parent, again, in a paradoxical way. And of course, with that increase in suffering, with sometimes these choices of these more severe interventions that are not necessary, rather than choosing palliative care and symptom palliation, you can get, again, that cycle that I talked about at the beginning, where actually the life-prolonging measures actually can decrease quality at the end of life, producing poor quality of death, and again, creating a reinforcing stigma about talking about death and dying. Now, in terms of what we do about this situation, how we can fix this, I'm turning it over to Geraldine, because she'll tell you what the answer is.
Thank you, Chris. Okay, just gonna, I do need you to stop sharing your slides so that I can share mine. In the meantime, good afternoon, everyone. Before I begin, I'll just like to share that I am experiencing some really nasty COVID symptoms today. So I'd just like to ask for your patience if I need some time to occasionally cough or catch my breath during the presentation. Thank you. Sorry, give me a minute. Okay, thank you, Prof. Chris, for that really enlightening presentation on death attitudes and concepts. So have we truly come up with the answer to embracing end-of-life conversations? Well, today I'm going to tell you about an exciting intervention the team at Nanyang Technological University implemented in Singapore a few years back that didn't intentionally attempt to facilitate any kind of death-related discussions, and yet organically succeeded in doing so. But before I get ahead of myself, I would like to bring you to where it first matters the most, which is the world of a dying patient. Now, imagine yourself being diagnosed unexpectedly with a terminal illness. You know, we all know we're all going to die one day, but we are rarely prepared for someone to tell us that this is it. And while you're still struggling with this piece of devastating news, you are being set up to go for a whole bunch of further tests and treatments with lots of medical appointments at the hospital and specialist clinics. Your life circumstances may have changed. You may have been the sole breadwinner of the family and now you're too sick to work. Someone at home may have had to quit their job or put their dreams on hold to care for you. Or your retirement plans of traveling, enjoying yourself, especially after COVID, suddenly don't seem possible anymore. You are in physical discomfort, to say the very least, and having to deal with everything is mentally and emotionally draining. And meanwhile, your caregiver, and in Singapore, it's often our family member, is also experiencing their own set of stresses, and how they respond to their challenges inevitably will have an impact on your quality of life and mental well-being. So all these combined can lead to a loss of personhood and dignity, which is a phenomenon that often occurs in terminally ill patients and their families. So now, in the midst of all these, imagine a healthcare professional coming up to you and asking you how you want to die. Here you are, struggling to live your remaining life with dignity, and someone is already full steam ahead asking you about your death. Is that dignified? Well, before we can answer that, we first need to know what dignity is. Dignity has long been discussed among philosophers and scholars, and the answer is always quite abstract. But we needed to know urgently what dignity specifically means to a dying person, which at the end of the day is really all of us. So Dr. Harvey Chochinov in Canada, in his extensive research, found that there is an intimate connection between every person's self-image and the way that they feel they are seen by others. And his research with the terminally ill showed that a personal sense of dignity can literally make the difference between a person's wish to live or die. And this just goes to show how tremendously important it is to safeguard a person's dignity, especially at the end of life. And so through 25 years of study, Dr. Chochinov's research team has found a consistent range of factors that can support or undermine a person's sense of dignity, when they are dealing with a terminal illness. And he categorized these into the model shown here. The first category, the illness-related constants, are made up of factors stemming from the illness itself that can affect dignity. So examples would be symptom distress, such as pain, and psychological distress arising from these symptoms. Functional and cognitive capacities are also factors that will affect dignity in this aspect because of the diminishment in independence as the illness goes along. The second category, the dignity conserving repertoire, demonstrates how dignity is affected by the way a person perceives the situation and how they respond to it. A personal sense of dignity, as we know, is often based on long-held notions of what makes people themselves, what makes you, you. And so with advancing illness, Dr. Chochinov found that people can still keep this sense of self and dignity intact by holding on to perspectives, such as being able to feel in control, maintaining their pride, maintaining the role in life, and having a legacy to leave behind, among many others. Finally, the social dignity inventory demonstrates how interactions with others can enhance or diminish the dignity that we feel. Whether one feels that one is being treated with respect and kindness, having control over our privacy, feeling supported by our friends and family, and having concerns about those that we are going to leave behind. All these have a powerful influence on our sense of dignity at the end of life. So these findings led Dr. Chochinov to develop dignity therapy in order to help conserve the dying patient's sense of dignity by addressing sources of psychosocial and existential distress. So during a 30 to 60-minute session, the therapist will ask a series of open-ended questions that encourage patients to talk about their lives or what matters most to them. This conversation, it's recorded, it's transcribed, edited, and then returned within a few days to the patient. And this gives the patient a chance to record the meaningful aspects of their lives and leave something behind that can benefit their loved ones in the future. So meanwhile, Dr. Andy Ho and his team in Hong Kong wanted to know if they could apply dignity therapy similarly in the Asian context. And when they examined Dr. Chochinov's model against their findings of perceptions of dignity in Asian patients and their families, they found some key differences. Asian participants emphasize the importance of strengthening and maintaining family connectedness throughout and beyond their illness, while family caregivers highlighted filial compassion and family integrity and support as necessary for a dignifying journey. So with such key differences in perspectives, it was then necessary to create a culturally appropriate intervention for dignifying end-of-life care. And so when Dr. Andy came to Singapore and joined the NTU team, he developed and tested a novel family dignity intervention, the FDI, which is based on the dignity therapy, as well as the Asian patient family model of dignified care, in order to create a supportive and constructive platform for patients and their families to express love and appreciation towards each other, to reconcile and forgive, to strengthen familial bonds, and to create generativity. Now, the protocol for the FDI is quite similar to that of dignity therapy. So the patient and their primary caregiver would be given a set of questions prior to the interview so that they could reflect on those questions and feel more prepared. The actual interview is conducted like a heartfelt conversation, with the therapist trained to facilitate meaning-making and dyadic expressions of appreciation between patients and their family members. The interview is recorded and transcribed. And once the family approves of the content, a written and structured narrative of their life journey together and expressions towards each other is made into a legacy document. And patients and their families can invite anyone they want to a reading of the legacy document. And at the end, they also get 2 personalized hard copies to keep or to pass down to their loved ones. Now, the FDI interview questions are structured in a way that really tells a coherent story about the patient's life and accomplishments and how their loved one's life intertwines with them. And so we would listen to memorable experiences in their childhood, to adulthood, and to the present to really ease them into that state of contemplative storytelling. And the questions that we ask also incorporate the opportunity for patients and their family members to say things to each other that could otherwise go a lifetime without being said. And besides the core questions that I'm going to show you, the therapist will also ask follow-up and probing questions to help facilitate the process throughout the interview, as well as the sharing between patient and caregiver. So some questions that we ask are, tell me a little about your life history. What are some of the most important and memorable times? And we actually go from childhood. How has your relationship with your loved one influenced your life? What do you think your or your loved one's most important and meaningful accomplishments in life are? What do you think your loved one is most proud of you for or appreciates about you? And what do you appreciate most about your loved one? Are there some things that you want to thank your loved one for? And what are some things you want your loved one to know about you or to remember about you? Are there some things that you would like to seek forgiveness for or offer forgiveness? What teachings, advice, or words of guidance do you want to pass on to your loved one and other family members? What are your hopes and dreams for the future, for yourself, your loved one, and your family? And in creating this legacy document, are there other things that you would like to include or to take time to say again? And really in our lifetime, how many people are going to ask us these questions? And when do we actually get to think about these? So running an intervention is really not enough. We need to ensure that the FDI truly work. So what we did was to conduct a gold standard randomized control trial, meaning that patients and families were randomly assigned to the intervention or control group to assess the effectiveness of the FDI for increasing patient dignity, reducing psychological and spiritual distress, enhancing sense of hope, meaning in life, quality of life, and also we wanted to assess the effectiveness of FDI for reducing family caregiver psychological and spiritual distress, hope, meaning in life, quality of life, as well as bereavement outcomes. And so as you can see, we had really high hopes for this intervention. So a brief look at our sampling size. We had 91 diets with a total of 182 participants, consisting of a terminally ill patient, age 50 and above, prognosis less than a year, with stable mental capacity, as well as an identified family carer. And all our participants were drawn from our collaborators, HCA Hospice, Dover Park Hospice, Tan Tock Seng Hospital, Singapore Cancer Society, and Methodist Welfare Services. So a brief look at the demographics. The mean age of patients was 69 years old and caregivers was about 55 years old. There were more male patients and more female caregivers. The spousal relationship made up more than half of the sampling, closely followed by parent-child relationship. And most of our patients were suffering from a form of terminal cancer. And these are the measures we use to test the intervention for outcomes in dignity, quality of life, spirituality, hope, social support and bereavement for both the intervention and control groups. We conducted baseline assessments of those measures before the start of the intervention, right after intervention, and then 1 week follow-up. So to assess the differences between intervention and control groups, we use Mann-Whitney U test. And to assess differences within the individual groups, then we use the Friedman test with post-hoc-Wilcoxon sign rank test. We also calculated effect size, meaning the magnitude of the intervention effect, with anything above 0.1 being small, 0.3 medium, and 0.5 large. So the paper of our findings is still in the midst of getting published, but I will be showing you some of the exciting results that stood out. First, between group comparisons. So we found that compared to those in the control group, intervention patients experience an increase in overall quality of life and perceived hope post-intervention and 1 week follow-up. Compared to control group patients, intervention patients experience significant increase in hope, having optimistic outlook on goals in life, and seeing that life has value despite the terminal illness at post-intervention and 1 week follow-up. Compared to the control group, intervention patients also experience increased spiritual well-being and a sense of purpose in life, as well as increased sense of social support at post-intervention and 1 week follow-up. Benefits also extended to caregivers. So compared to the control group, intervention caregivers experience significant reduction in caregiving stress at post-intervention, and this remained below their baseline at 1 week follow-up. Intervention caregivers also experience a significant increase in being able to accept their loved one's illness and embracing the impending death of their loved one across post-intervention and at 1 week follow-up. Further post-intervention evaluation responses from our participants. 100% of patients and caregivers are satisfied with FDI, and more than 85% of them identify FDI to be as important as other aspects of their healthcare. And that's really cool because they think that FDI is just as important as whatever chemotherapy that they're going through, whatever palliative care medical treatments that they're going through. And this really says a lot. More than 80% of our patients and caregivers found FDI helpful in terms of improving their quality of life, their spiritual well-being, lessening their sense of sadness, helping them feel more valued and worthwhile, helping them to accept the way things are, feeling more respected and understood by others, helping them to find life more meaningful, enhancing their sense of dignity, and reaffirming their personhood. More than 70% of patients and caregivers found FDI helpful in terms of looking after unfinished business, so saying what they had to say, lessening sense of being a burden, having greater control over their lives, having an enhanced sense of purpose, reducing the sense of suffering, facilitating appreciation within the family, and even enhancing their will to live despite terminal illness. I would also like to share with you some personal feedback from our participants after the experience with the FDI. So this patient said, "For the first time in my life, I feel like somebody really understands me as a person. Somebody sat down and asked me all these questions about my life and really listened. Nobody ever asked me about these things before, and it felt very good. Another patient said, normally my daughter wouldn't even say I love you to me. She rarely says it. However, when she finally said I love you during the interview, I could feel that she really meant it. So as you can see from our findings so far, the FDI has very much achieved what it set out to do. So what happens when people begin to feel dignified, respected, valued, and like their own person? Well, something else unexpected occurred that we had not counted on measuring, which is patients started talking about their deaths organically during the session. So during the sessions, we never once mentioned illness or death. But during the interview about their lives, patients felt empowered and emboldened to shape the story of their death. So for instance, one patient when asked, what would you like your loved one to know about you? So just one of the questions in the FDI interview. He began his end-of-life discussion so confidently with his family. And this phenomenon occurred repeatedly throughout our interviews with many of our participants. And one caregiver said, we didn't know that he wanted to die at home. We were going to let him stay in the hospital because he never said otherwise. But now that we know his wishes, we will do our best to fulfill them. And so the team quickly realized that a life-giving narrative was ironically a great way to opening the doors to a death conversation. And why is this so? As our patient stated so aptly, because if you do not ask me about my life, how can you ask me about my death? We know that in Singapore, we live in a superstitious and death-fearing society, which are obvious barriers to end-of-life conversations. At the same time, because we are generally a collectivistic culture, our desire to exercise filial piety, familial obligation, and to just not rock the boat can further confound our death conversations. And meanwhile, the KPIs and efficiency expected from advanced care planning or AMDs, they actually do very little to alleviate these barriers and instead can unintentionally add to them. So have we come up with the answer to defying death taboos and embracing end-of-life conversations? Well, I truly think so. However, as with every policy that gets pushed through, every major revision in structure, we need research to advocate for change. And I believe that the next step is to conduct a randomized control trial using FDI as a prelude to advanced care planning and to assess its effectiveness as compared to the usual ACP protocols. And I think that if we can do this, I believe we can actually change the face of ACP in end-of-life conversations, not just in Singapore, but really trailblazing this throughout Asian societies at the very least. So this is really something very exciting that our team in NTU looks forward to doing, hopefully in the near future, because we really need to change the narrative of the death conversation itself from something distressing and stressful and scary to something enjoyable even. Just imagine that. And so I would just like to leave you all with this. The most important and meaningful stories in our lives are actually our own. And so just as we honor our lives by telling our stories, we can honor our deaths by doing the same. And the end-of-life conversation must be dignifying, empowering, and meaningful, a lasting legacy and a story in itself. And perhaps only then can we finally overcome a culture of fear and create a culture of dignified death acceptance and literacy for our future generations. Thank you very much.
Thanks, Ms. Geraldine and Dr. Chris for your sharing. Although this topic may sound quite heavy, but I believe all the audience can feel the positivity in the message that they try to convey. So there's so much positivity in terms of good death, in terms of successful dying, and it's not just benefiting the patients, but also for the family as well as the caregivers. So thanks for the inspiring sharing. So I have a few questions over here. I think some of these are related to the study that Geraldine shared just now. So I would like to address those questions first. So this question asked about, in the study presented, could the increase in all the positive outcomes be due to the fact that patients were just able to express and talk to someone and not necessarily the therapeutical approach itself?
Thank you for that question. So definitely we took that into consideration. So I do want to also state that for the control patients, so both intervention and control patients were receiving psychosocial support from counselors and social workers. So in terms of the usual talk therapy, they were getting it. So control patients had the talk therapy, intervention patients had the talk therapy and the FDI. And so there was that difference between them.
Okay, thanks. There's another question from Mohammed Izzat. He was curious to know if FDI is as effective to younger patients.
Oh, thank you for that question. You know, that is really something I want to find out as well, because I used to work with terminally ill children and their families, and we would do ACP with them. And I think this would be a really wonderful way for parents to also solidify their memories with their children before their children die. But then again, at this point, like a lot of things, we need research to prove this. And doing research with children, terminally ill children, can be difficult due to the gatekeeping, ethical issues, etc. But definitely something we want to look towards. And on that note, even like dementia, people with early onset dementia, this could happen as well. So many possibilities, in fact.
Okay, thank you. Okay, so now we have some questions for Chris. We have a question from Claire. She says, thank you, Dr. Loh. Your presence is very calming. You raised some poignant points around conversation about dying. I'm interested in researching the challenges facing people with a life-limiting condition who wish to enact legal voluntary assisted dying in a home environment. Obviously, there's a synergistic relationship between conversations around dying and the ability to enact VDA. Do you have any thoughts on this topic, or are you aware of any research within this area? And another similar question from Paul. Thank you both speakers for the insightful sharing. And Prof. Loh, how did you feel might be the best way to address collusion? Would you feel it's more useful or viable to target family members with psychoeducation to address the concerns of the physicians? Of course, there's another question about euthanasia as well as a subject that comes up during conversations about death. And what are the opinions on euthanasia? Are there any positives? How can its stigma be reduced?
Okay, maybe I'll talk about euthanasia first. I don't know actually the state of the law about euthanasia in Singapore, if it's even legal or if it's an option. I can only really speak about it in the context of Canada, where VAD is called MAID, and it's called medical assistance in dying. And that was legalized maybe just about 5 years ago or so. And it is an option for people with a life limiting illness, such as advanced cancer or other kinds of diseases. As long as I think as long as the death is foreseeable, I think is the wording, then actually someone can apply to go through MAID. And the MAID process involves both a psychiatric assessment done on at least one occasion, and then repeated to ascertain whether or not the desire to die, to have assisted death, is persistent over time. I think we find that the reasons for people choosing MAID were not necessarily the ones that actually the law was constructed initially with people in mind. I think the idea initially was that, or the thinking was initially that it was people who were in extreme physical suffering of some sort. Yeah, it could also be emotional suffering, but extreme physical and emotional suffering that was acute and that was intolerable, right? Such as, for example, you can imagine yourself being in extreme pain that's unrelenting. And so MAID might be an option, right, that you would want to choose because there really is no other option, right? But it actually turns out that the most common reason for people choosing MAID is actually for existential distress, broadly speaking. And this actually includes what Geraldine was talking about, really issues about dignity and the loss of dignity. And oftentimes these were kind of fears about the future that hadn't yet occurred. So actually the amount of physical suffering that a person is in is kind of limited at the time that the MAID request comes. Rather, they're anticipating the future and they're thinking, you know what, I just don't want to die in this way, in this prolonged and awful way that I imagine. And I want to have that option. And I want to be able to choose the timing of my death. So for example, many people would prefer to die at home if given a choice. And so in some circumstances, MAID can be done, you can choose when and where and perhaps also how it's going to happen. And I think that's what we find actually. It's the psychological aspect of control, yeah, over the timing and the manner of death, that what brings the kind of relief from the existential distress that people may be experiencing in an anticipatory fashion. Oh wait, there's something else, huh? Was there another question? There's something else that someone wanted to ask about?
We can also talk about a question by Paul. How do you feel the best way to address collusion? Would you feel it's more useful or viable to target family members with psychoeducation to address the concerns of physicians?
Oh yes, sorry, you know what? Just one more thing about the assisted dying, okay? Just one more thing. Actually, a lot of people find that, interestingly enough, the benefit of assisted dying is actually not just about the death. It's not just about death itself. Yeah? It's knowing that there's an option. Yeah, if things go really bad, I have the option of this. So actually, some people, I'm not sure what the percentages are just yet, but some people will actually go through and get the permission to do MAID. And they just said, but not yet. I'm still okay, not yet. But it brings a lot of peace of mind to know that if it ever gets really bad, then they can have that option. And in fact, I think there's quite a number of patients who actually get the option. They never wind up choosing it because actually it never gets that bad. And then they actually pass away. Yeah. So sometimes it's the peace of mind knowing that I have a choice. Yeah. That itself is a powerful kind of powerful clinical benefit, rather than actually, strictly speaking, the termination of life in and of itself. Okay, coming to Paul's question, which is about collusion. How to prevent that? I think the more FDI, yeah, the more people learn about FDI and the fact that, look, this is what can happen from the discussion about death and dying, right? It's not always going to be a terrifying thing for everyone, that it can actually bring families closer, I think the more that people understand that and can see that evidence, then that's a major step actually towards promoting, a change in cultural attitude and preventing collusion, including actually among the healthcare providers themselves. Yeah. I recently read a study that at least comparing Taiwan, Korea, and Japan, about the rates of discussion, like the diagnosis, yeah, like the timing of it and who gets told first. And in some cases, it's only 5 or it's under 10% of Japanese patients may be told explicitly about their diagnosis. It's not, of course, quite clear, actually, the nature of that. Sometimes there's differences in communication. So it might be that maybe in a Japanese setting, actually the information is communicated, just not explicitly, and it's just done more implicitly, right? And within that cultural context, perhaps it is understood. But that ambiguity is uncertain, and we don't really know. But I'd say that some part of that hesitation is actually on the physician side as well as on the family side. And I think, that has to be tackled in both ways, both maybe also the destigmatization of death among the healthcare team, right? Who themselves actually have sometimes a lot of death anxiety. They actually sometimes, in the same manner as the family, want to protect actually the patients. Yeah, they think actually by withholding information, it can be protective. That's actually not the case in most cases. Yeah. But the issue is the same, addressing the family and addressing the healthcare team. It's the same underlying kind of attitude. So I think things like FDI, really showing that evidence is quite crucial.
Okay, thank you. So we have another question for Geraldine about the study. Brian was asking whether if you might be able to share what the ethnic breakdown was in the trial.
Off the top of my head, I can't give you the exact numbers, but what I do know is that the breakdown does follow Singapore's general ethnicity breakdown. So it was a majority of Chinese, followed by Malay, followed by Indians, and followed by other ethnicities. We will give a proper breakdown in our paper. So if you are interested in looking at the full paper with its findings, do get in contact with me. I'm sure my email is around somewhere. And yeah, I'll send you the paper when it's out.
Okay, yeah, thanks. So we have some comments from Ilona. I hope I pronounced the name correctly. So she commented that the topic is very relevant in Australia's multicultural population, and she also suggested or commented that dignity and compassion are such significant concepts, and best wishes for your recovery from COVID, Geraldine.
Thank you.
Okay, there's one last question that I would like to ask both of you. How would these conversations about death change, if at all, when the average human life expectancy increases?
I see Chris sort of like giving me the Jerry go first. Well, I think that firstly, death conversations will become even more important as life expectancy increases. Why? Because just because we're living longer doesn't mean we're healthier. So in fact, current studies already show that although we are living to like 80 plus, 90 even, we are riddled with tons of illnesses that could limit the way we live our lives, that could limit our dignity or tear it down completely. And I think death conversations are not just about how I want to die, but how I want to live my life with dignity in the meantime. And like what Chris said just now in answer to the question about euthanasia, how people want to know that they have a choice or like there's a way out. And I think for people to know that, hey, I am in control of my future, even though I'm very sick right now, there is a plan for me. So this is the treatment that I want. This is where I want to die. This is what I want to tell my loved ones. And sort of just really going through all the unfinished business, even though, they may not be at death's door yet. I think that in itself can be very helpful. And I believe that that can even result in, and this is probably a study by itself, but having a death conversation can perhaps even result in lesser hospitalizations for people, a better quality of life and physical quality of life in both patients and caregivers. And these caregivers especially, they're going to be patients one day themselves. So they need to start early to, have a better quality of life in order to have a better quality of health. So I think in general, death conversations are going to be so much more significant in that sense. Over to you, Chris.
Yes, well, I think we have to understand that life expectancy increases are partly associated with the technological changes and medical advances, right, that our society is now capable of. So there are ever increasing life prolonging kinds of measures, but also greater technology, the greater health awareness, right? So that people are kind of more taking care of their health and actually have more means to kind of improve their longevity. Paradoxically, though, I think that given that whole context, I think actually I do have a concern that death is actually getting more and more, like you see it less and less in some ways, right? It's more and more hidden in many ways. And I do think that with the increase in life expectancy, I think somehow it's associated with, oddly enough, more stigmatization of death. Yeah. It just becomes something that it becomes more difficult to talk about, more silent somehow. Yeah. And I think, in some ways it ties in the literature on the medicalization of death. It's something that happens and it's hidden away in the wards, right? In the medical establishments. And the body is wheeled away and you don't even really get to see sometimes the people or what have you. So I think paradoxically, as life expectancy increases, I think there's also maybe more and more impetus to not want to think about death. Yeah. And I think that actually has to be combated. Yeah. Actively.
Okay, thanks. There's one last comment, one last question. Will the PowerPoint slides be shared? I'm not sure how this can be shared, but I think if you are interested in their presentations, you can approach the presenters for further questions. And if they're willing to share the PowerPoint slides, they can share via the emails. And the recording will be available as well on YouTube. So probably a few weeks after this, you'll be able to find the PowerPoint, the recording of these sessions. So before we wrap up, can I ask Geraldine and Chris to make any final comments that you want to make?
Sure, I'll start. Thank you for attending. I know that this is not an easy topic. I also know it's the ghost month. So you know what? I hope you've learned something from this discussion, and feel free to get in touch. Thank you.
Yes, I also want to thank, I also want to thank everyone for coming and listening to this webinar. I think, just coming to listen to a discussion on end of life and death is something very encouraging. And we do hope that you will be able to share what you learned today with the people that you know. And also, I always feel that, if you're someone who wants to advocate for death conversations, start with yourself and start at home. So if you want the FDI questions, I'll be very happy to send them to you and have that conversation with your loved one. And then you'll see how powerful it is. And then when you advocate for death conversations, it's just going to be so much more authentic and powerful. Thank you.
Okay, thank you. I would like to thank the panelists today, Geraldine and Chris, for the inspiring and meaningful sharing. And then to the audience, thank you for joining us. So I'll see you in the next Emerging Leaders Series session. Bye.